Okay, so welcome everyone to today's session. Let's code together. My name's Jane Knight. I'll give you a wave, and I'm joined by my colleague, Dr. Caroline Wilson, one of our medical officers.
Hello.
So the first slide explains that MEDRA came about in the mid-1990s. It was an ICH initiative, and at the time, the MSSO was put in place to maintain and distribute MEDRA. The activities of the MSSO are overseen by a management committee with representatives from the industry and the regulatory authorities across all the ICH regions. The next slide is a copyright notice explaining that MEDRA is owned by ICH, so is the material that you're going to see today. As I mentioned, we don't share the material, so if you do quote it in any way from the recording, you need to make sure you acknowledge ICH. We want it to be interactive. I explained, just for those of you who were with us just earlier, that we do want you to ask questions and make comments, and we'll stop throughout the session to talk about your questions and comments. Sometimes we may not all agree on the coding of a term, so we have to agree to disagree and move on. We can't take requests today to code specific verbatim terms, but what we do have at the end is there will be a survey that you can submit suggestions for future topics or questions. And we do try to come round to these, maybe not in the next session, but over time we do review them. And many of the sessions today have come from suggested terms. This is how you join the polling. The easiest way is to scan the QR code on the right-hand side with your smartphone. That will allow you to join directly. But as an alternative, you can open an internet browser, so something like Safari or Chrome or whatever you use, and you can then just type in polev.com as the URL. Nothing else. Just polev.com. You should then see the screen that's shown on the right-hand side, and you enter my name, Jane Knight 855, and this will then link you. So if you can't do the QR code, or if you want to do it on your computer, you can do it this way as well. And if you need to have the QR code again, just let us know in the chat and we'll show it again. So here's the first poll. Where are you joining us from today? I see a number of you already there. It's working well. I can do some of the countries, but Caroline, you're a lot better than me on geography. Few of you from
Russia, of course.
Russia.
The Philippines, someone in the Indian Ocean. India's there, Spain, Portugal, Italy, Scandinavia.
Lots.
And the US, very early for the US. Yeah. Canada.
Canada, welcome. Where
early bird
in the world?
Joining.
Welcome. Very early. Great to see. Always a real privilege to be able to do this. So welcome.
Yeah, welcome everyone.
Here's the demo password that I mentioned. You may want to take a screenshot. You don't have to use it. You don't have to use the browser, and you can use your own. This is where you find it on the website. I think you're all probably well familiar with that now. Just as a reminder that sometimes when we do have challenging terms, they may not always be an exact match. Sometimes there's more than one possible term that could be selected, and you'll see that in some of the examples today. Even the points to consider document sometimes offers options for term selection. Sometimes it's a case that we understand the term differently. And overall, we always try to represent events by a best approximation. Always code as reported without making any assumptions. That's a point we're going to emphasize during the session. And we always have one of these pictures. So this is an interesting one. What is it? And this here I've seen as the importance of seeing the bigger picture. Now, there's obviously something going on there behind all these discs, these concentric circles. It's not the Ebbinghaus. That one's left over, I believe, from last time. So the best way to do it is either to lean back in your chair or look at it from side on. And you can see me, I'm doing it here. So lean right back in your chair, look at the bigger picture, forget the circles, and just let your eyes see the bigger picture and see what you see. Hopefully, we don't have a poll to ask what you see, but hopefully you'll all be able to see a face. And so coding is very much like this. It's not an exact science, that you do have to consider the bigger picture. And sometimes we have different perspectives on a term. So you can see this picture from different perspectives, you get a different overall image. It's about using medical judgment, balancing the risk and applying rules. Give us consistency with medical judgment. Medical references are essential for accurate coding, and that's something you'll see today as well. And sometimes there isn't the right concept in MEDRA, and you can look for a synonym first of all. If not, you may choose to use a term which is maybe slightly more general, or it may be that you need to ask for a new term to be added to MEDRA. So having said all of that as our introduction, let's code together. And I'm going to turn my camera off because I know it can be distracting. So our first example today is difficulty in talking. So when I see this term, I think about, well, what sort of difficulty are we talking about? Do we know what's causing the difficulty? And if not, do we need to get clarification from the reporter, or can we confidently assign an appropriate LLT? It doesn't look like a very complex term, difficulty in talking, but when you actually come and look at it, you realize what we haven't been told. Do we need more information? Ahead of the session today, I've selected a few terms which relate to talking, dis meaning difficult, and so we've got dysphasia, dysarthria, dysphonia, speech disorder, a more general term, incoherent, or do we seek clarification from the reporter? Which of those would you select? Or maybe you would look to select something completely different. The poll's working. I'll just give you a moment to vote. Yes, let's see where your votes are lying. You still should be able to vote. I'll just move it on to the next stage. So it's still open. Speech disorder is by far the most popular here, but quite a significant number of you are wanting to seek clarification, maybe to find out the reason why there's a difficulty in talking. What type of difficulty is it? Because as you see, dysphasia, dysarthria, and dysphonia can be very different, and I'll explain more about that in the browser. So speech disorder seems to be the most popular choice. So let's look at what Dorland's Medical Dictionary says about dysarthria. It's defined as a speech disorder consisting of imperfect articulation due to loss of muscular control after damage to the central or peripheral nervous system. So it's a mechanical problem, dysarthria, about articulation of the words through movement of the mouth. So that's what that one means. It could cause a difficulty in talking, but we don't know that that's what's happened to this patient. Dysphasia is, again, dys for difficulty, phasia this time meaning the speech or the words there. This consists of a lack of coordination and failure to arrange the words in their proper order. Again, suggestive of a central lesion, telling us here in Dorland's what this is a typical symptom of. May also be called other things. There's aphasia, is where the patient is not able to speak, a meaning lack of speech. So we don't know that here either. Dysphonia is an impairment of the voice, a speech disorder or difficulty in speaking. So this is the actual sound that comes out. But looking back at our verbatim term, difficulty talking, we don't know which of those. It could be dysarthria, that there could be dysphonia. We just don't know. So I'm going to go now to the browser and I shall look at the location for some of these terms to just see if we can find out a bit more about it. I'll log on to the web-based browser. just as you would do. So now let's have a look. Let's put talk in first of all, because we always say you should start with the reported words and see what we get. Do we get anything there in talk? No, nothing relevant. I looked down the list, nothing there relevant of a talking disorder. So I'm now going to think about a synonym. That's our next step when we're coding. Looking for a term, speech disorders. So what do we have in speech? We've got disorder of speech, disorganized speech, poverty, pressure. Again, very specific, which we haven't been told about. Is their speech slurred? Is their speech delayed? They've got a difficulty. Is it speech loss? No. Is it slurred? Again, very specific terms. So let's have a look at speech disorder as a general term. That was your most popular choice in the poll. On the right-hand side, when I put my cursor on in the browser, you always see the location of that term. We can see that the PT, speech disorder, is multiaxial. It's in 3 system organ classes. The primary is nervous system disorder under the HLT of speech and language abnormalities. But as we can see, there are at least 2 other places in MEDRA which have groups of speech disorder terms. We've got speech and language usage disturbances in psychiatric. We've got upper respiratory signs and symptoms within respiratory, thoracic and mediastinal disorders. This would be more for the voice elements of it, the breathing, the voice, the generation of sound. So you see that we could have a look at various places for more specific terms. I'm going to do a right-hand click, go to the browser, look at the term in relation to the its brothers and sisters. Under speech disorder PT, we have a number of LLTs here. We have babbling, lisp, mumbling. So things which are more general, that there is a difficulty talking. So having seen this, I'm inclined to agree with all of you that speech disorder probably is the closest. We can have a look at the other, there's dysarthria there. That's the mechanical articulation problem. That would cause a slurring of the speech. And it's about but we don't know that. As we said, we don't know that in our dyslalia, dysphemia, dysphonia. It's green here because it's actually, this is the voice term. It's actually primary elsewhere. This is the secondary location. It's primary to respiratory. And that's, as I mentioned, it's because of the voice. But we don't know that. We don't know that the difficulty in talking relates to the voice. Same as I put incoherent in the, we don't know that they're incoherent. We don't know it's dysphonia, dysarthria, or dysphasia. Dysphasia is in the cortical disturbances, I think, isn't it? Dysphasia, no, where did I, there it is, aphasia is there. Come down, there's dyspraxia, dyscalculia, no. Anyway, dysphasia, that's the one with the word order. That's not ideal either. Let's just have a look for completeness to see the exact location of it. It is under aphasia. I thought that was where it was. That's in the cortical disturbances, HLT down here. Cortical dysfunction. So let's go back now to our slides. I've summarized it on the slide for you. I've shown you where the selection of terms are. So I think the learning point here is to be very inclusive in your search. Have a look at all the possibilities, think around it, but don't make any assumption. And here I've just summarized for you so you can see just where in MEDRA there are speech-related terms. So if you have any speech-related terms in the future, remember that you may need to look in several different SOCs to find the closest one to the reported event. Be aware, I've just mentioned, use top-down browsing as well as bottom-up. This is what we mean top-down, is where you go to the system organ class and look around, browsing within the SOC. Otherwise, you might miss terms. Don't just look for talking, look for the synonym of speech. If you're not sure, you can seek clarification. I know a number of you were suggesting this, and if that's possible to do, then it's always a good idea to find out the reason for the difficulty. I agree with you if that is possible. But if it's not possible to get more information, then you would select a non-specific term, and here we propose speech disorder. Okay, any questions, Carol Ann, on that one?
There's one question. Why not use articulation problem?
I think for me, articulation is the movement of the jaw. That's how I see it. Just as a joint articulates, the jaw itself articulates, and I would see that as the movement. And I'm not sure that I feel comfortable at making that assumption.
No, it's more specific than speech disorder. I agree.
It's more mechanical, isn't it, articulation?
Yeah.
Any other comments or questions or anything you'd like to add, Caroline?
No further comments or questions, Jane.
Thank you. So let's move on to the next one. This one's got some parentheses here, so let's see what we can make of it. If you don't catch all the details, Caroline's kindly putting them in the chat. So if you lose what the term is, you can see it in the chat. Gastrointestinal bleeding, hematochezia, and occult GI bleeding. So what have we got here? We seem to have at least 3 elements that I can see. We've got gastrointestinal bleeding, but it doesn't tell us where in the GI tract. Hematochezia. So we'll have a look and see what that means shortly. Is that a symptom? And then we've got occult GI bleeding. So is this a symptom or is this a test result? If it's occult, it's probably a test result. So do we have a diagnosis there? Do we have a symptom, a combination? Can we prioritize, or do we need to split code here? Can we select one term, or do we need to split code? And we may need to refer to the MEDRA term selection points to consider guidelines in making that decision. Again, let's start with Dorland's hematochezia. It's the presence of blood in the feces. So quite general, really. It's hemato, blood, chezia meaning defecation. So presence of blood in the feces. Doesn't tell us what type of blood, if it's occult, if it's fresh blood. It doesn't tell us here with this definition. Referencing. So the standard methods for detecting occult blood are based on detecting hemoglobin or its breakdown. And the most common method here that I think we've done examples on this one before, is the Guaiac test. And you'll find that in MEDRA Guaiac. It's commonly used. It detects fecal occult blood and it detects heme from the hemoglobin. But there are other immunological methods that are more specific. These use antibodies against one of the components, more commonly against the globin, the hemoglobin chain of the globin, whichever way, I don't know how you pronounce it. But Guaiac and the immunological methods can be unreliable in detecting upper gastrointestinal tract bleeding because the hemoglobin may be digested. So if you think about it, if it's high up in the stomach, for example, the blood's got to travel through the digestive tract and the intestinal enzymes there will break down the proteins and digest the blood. So it's more difficult then to detect in the stool if it's been digested. However, it's not quite, as we'll see shortly, it's not quite as straightforward as that. So what we know so far, what would you select? Gastrointestinal bleeding, upper gastrointestinal bleeding, lower gastrointestinal bleeding, hematochezia, blood in stool, or occult bleeding test positive. And you should be able to select multiple terms here if you wish. Oh, I see the votes are rocketing up. So you are selecting several. I can see by the numbers. Well done. Does one of these capture everything, or do we need to select more than one? And what sense can we make of these 3 elements together? Again, this is a real term. We've taken it exactly as it was reported. This is why when it came to us, we had these brackets in it. Maybe that was part of processing, wherever it came from. Okay, let's see where your votes are. So we've got gastrointestinal bleeding. So you haven't, only a couple of you have selected lower, but so that's good. Gastrointestinal bleeding, that's what's been reported. Hematochezia, again, that's what's reported, and that's always what we say to do. And occult GI bleeding, occult bleeding test positive. So your most common, your most popular choices are what's in the verbatim term. Well done. Blood in stool would be a synonym, another way of saying it, but we've got occult bleeding. We know is more specific because it's occult. We don't know if it's upper or lower. That information hasn't been given. And can we make sense of it? Can we find out, make the judgment based on the other information we've given? So far, no, nothing I've seen so far makes me want to assume it's upper or lower. Well done. So let's have a look at some more references. This is the MSD manual. And we see here we've got some definitions or descriptions of the conditions. Hematochezia is the passage of gross blood from the rectum, usually indicating lower GI bleeding, but may result from vigorous upper GI bleeding with rapid transit of blood through the intestines. So this reference is telling us that it's more like a fresh blood, rather than occult blood, hematochezia. It's gross blood. So you either would then think it's coming from low down in the tract, or if it's a very heavy bleed and it's passed through quickly, there may not have been time for it to be digested. So it may come out as more like fresh blood, depending on the transit speed through the gut. Melena is very different. It's black, tarry stool, indicating upper GI bleeding, but bleeding from a source in the small bowel or right colon may also be the cause. So again, even with melena, you can't make any assumption. It tells you there how much blood needs to be lost to create melena, this black stool with a large amount of blood which has been processed or partly digested. Then we've got chronic occult bleeding, could occur from anywhere in the GI tract, detectable by chemical testing. So I think this is telling us that we can't make any assumption based on whether it's reported as hematochezia, as fresh bleeding, or occult bleeding. We can't make any assumption whether it's high or low in the tract. We go now to our MEDRA term selection points to consider. When we have two pieces of information, does the PTC tell us how to prioritize? Well, we know that if we have a definitive diagnosis with signs and symptoms, the preferred approach is just to code the diagnosis. But do we have a diagnosis? And do we have a diagnosis which is consistent with all the other reported information? And I'm not sure we do. We also have guidance in the points to consider that says that if splitting a term, and i.e. selecting two or more LLTs, if that splitting provides more clinical information, then that's what we should do. So here, maybe we should be splitting because we can't assume that it's high or low. We know that there's gastrointestinal bleeding, but by coding the other elements, we may be able to capture more information. So firstly, learning from this, we need to understand all the reported elements in the term and reference those. Identify the initial causative condition, if we can, and subsequent symptoms or lab results, and then follow the guidance from the MEDRA term selection points to consider. So overall, firstly, we would try to get clarification from the reporter. Here, only the reporter knows the site of the bleeding or their judgment. We can't see the patient. We can't decide based on what's reported the exact site of the bleeding. As we've said, we've got more information if we code the individual elements. We don't have an overall diagnosis of what's bleeding in order to say that the other two are both covered. The hematochezia with the gross blood in stool as well as the occult bleeding gives us more information. So at this stage, while we seek clarification, we would code all three elements. Gastrointestinal bleeding, hematochezia, and occult bleeding test positive. Caroline, anything to add on this one? I know you did the research on this one for us. So have you got anything else you'd like to add that I've missed, or any comments from our group today?
There's one question. Can we code it as gastrointestinal hemorrhage only?
Well, hemorrhage and bleeding are synonyms, so bleeding is closer to what's been reported. You could, but like we've said, it's quite general. It's not showing the high bleeding or low bleeding. Hematochezia tells us, based on our understanding of it, that there's more like fresh blood. And the occult bleeding test tells us that there's hidden blood. So those two pieces together give a little bit more information, give us that bigger picture that we were talking about earlier with our diagram, our picture today. Look at the bigger picture, and we're able to fill in more information by coding everything. What would you say, Caroline, to that one?
Yes, I agree. Yeah, we had long discussions about it, how to approach it. Of course, you could strictly follow the PTC guidance and say, well, gastrointestinal bleeding is the final diagnosis. But in this instance, the test results or the hematochezia, they provide a bit more information. And that is why we decided that it would be appropriate to split code here.
Gastrointestinal bleeding is quite general, really. I feel that I do want to know more information. Well, what's bleeding? Where's bleeding? How much is bleeding? So that's why we decided, if possible, to code everything. Okay.
Yeah, and there's one question, and that's, of course, especially in clinical studies, sometimes you have difficulties split coding based on data management processes. And so the question is, can we use one MEDRA term only, the gastrointestinal bleeding as well, if split coding is not possible based on a database, so technical issues or processes that are defined? Yes, of course.
You would, yes.
Yeah.
From my experience in clinical trials, you would. If you can't code everything, you would. We're telling you our ideal, but yes, you would. Because gastrointestinal bleeding does cause the other two. As Caroline says, it's a diagnosis of sorts, quite general, but sort of diagnosis. But ideally, if you can, particularly in pharmacovigilance, we would suggest you code everything. Okay, I'll hand over to you, Caroline, for your next two examples.
Yes, let me take over. And here I am. You see my screen, Jane?
Yes, absolutely.
Okay, so let's continue. Next, it is reported that the patient is feeling a loss of strength in the hands. So this seems to be straightforward again at first sight, but is this a subjective experience of the patient or an objective finding that was confirmed by a test, for instance? How would you handle this verbatim? What LLTs or LLTs would you select here? And here are the options. Would you select feelings of weakness, strength loss of, feeling abnormal, muscle strength abnormal, hands weakness of, or grip strength decreased? What would you do? Feeling of losing strength in the hands. Voting. So let's see what you're going for. Most of you are going for hands weakness off, but others would also consider feelings of weakness, strength loss off. So we have a split of opinion, also grip strength decreased. But most of you would consider to code to hands weakness off. So let me close the poll and switch to the browser. Where am I? Here. Here is the browser. I have to log in. So Let us search for the coding options that we had in the poll. So feeling of weakness was one. If I search for it, here it is. It's grouped under asthenia. So something, if I right mouse click, go to browser, asthenic conditions. So this is debility. This is not actually weakness, generalized strength, loss of. This is actually not what has been reported. It's a specific finding. It's a feeling of weakness in the hands. So asthenia would not be appropriate. What about, because it's a feeling only and we are not sure whether this is really an objective finding or whether it's just a feeling that has no objective background, we could consider the PT feeling abnormal. Here it is, feeling abnormal. And if we go to the browser again, you see it's in the general disorders system organ class, and there's a lot of LLTs underneath. Feeling floating, feeling miserable, feeling stoned, feeling poorly, bad, spaced out. So really feelings, strange wordings where one cannot catch a real medical background. It's just a sensation of feeling bad or different than before or in other instances. Muscle strength abnormal was another one. Here we are. Here it is. So let's see the hierarchy. Go to browser where this LLT is located. So this is considered an investigational result. It is grouped in SOC investigations, as you can see here. Muscle strength abnormal and no investigational result was reported here. It was a feeling of the patient. So this one would not be appropriate. And the same actually holds true for the grip strength. If I search for it, so grip strength, go to browser. Again, it's in investigations. And here it is, grip strength decreased. But this again, it was not reported that this was a test result. It was a feeling of the patient. And the other option that we had in the poll, and most of you went for or voted for this, was hands weakness off. And here it is. Go to browser again. It's grouped under SOC musculoskeletal. And if I click on it, here it is. It's grouped under HLT muscle weakness conditions. Here it is, muscle weakness. And there's a general muscle weakness and also weaknesses of other parts of the body. So trunk, limb, and here's our hands weakness off. So let me switch back to my slides here. So when coding similar terms, similar verbatims, always distinguish between objective and subjective findings. One wouldn't code a feeling of having a heart attack, for instance, as a myocardial infarction. So you have to be very aware that feeling of terms can be completely different from objective diagnosis. But you have to be aware that some medical conditions are subjective in nature. So provide some guidance to your coders by defining the conditions that are subjective in nature with a few examples and by providing options for coding other feeling of conditions. And these could be discomfort, PTs, or a suitable LLT under a feeling abnormal, the feeling abnormal PT as well, or PTs that contain the information abnormal sensation. And I can show them in the browser, and you will see that MEDRA really handles these terms very differently. So if I have feeling something with chest, feeling hot feeling in the chest, it's grouped under chest discomfort. Distressed feeling, it's again chest discomfort. So this would be a discomfort term for a feeling of some abnormality in the chest. Or we have feeling something with the eye. Eyes feel sticky. Abnormal sensation in eye. So here we have an abnormal sensation term. And I've shown you the terms, the LLTs that are grouped under PT feeling abnormal already. So these are the terms that you can look for: abnormal sensation, discomfort, for instance, and also as an option, the PT feeling abnormal that you could select for similar verbatims. So with this, we would suggest to code this verbatim to hands weakness of. The wording describes a subjective feeling, but due to the reference to the weakness in the hands, so making it more specific, we would rather understand this as an objective perception by the patient. And most of you voted for it, so well done. Any questions, Jane?
The only comment we had, Caroline, was the suggestion of the term feelings of weakness.
Yeah, feelings of weakness, but this, as I've shown in the browser, is grouped under PTSD. So it's more the general feeling of weakness. It's whereas here it's really specified as a feeling of losing the strength in the hands, and it's more specific wording. And I would not consider PTSD in this instance.
Yes, absolutely. It's more specifics. Just the hands are mentioned. Yes, thank you. No other comments.
Okay, then let's continue with the next one. So here a low energy femoral shaft fracture is reported. So the verbatim is clear and precise, but is the information low energy important? Do we have to consider this for coding purposes? And is it a traumatic or is it a pathological fracture? How to decide that? And what would be the most appropriate LLT for it? Again, your turn. Or which LLT would you select here? Femur, shaft fracture, pathological fracture of femur, osteoporotic fracture, fragility fracture, spontaneous bone fracture because it was a low energy fracture, or traumatic fracture because still there was some impact, external impact on the patient leading to this fracture. It was low energy, but still can be considered as a traumatic fracture. What would you do? So most of you are going for femur shaft fracture, but there are others considering pathologic fracture, fragility fracture, traumatic fracture. So most of you would prioritize the site here, the femur shaft, that the femur shaft was affected by the fracture. So let me close the poll. And again, switch to the browser. Here we are. So if I truncate the verbatim and enter FEM in order to capture femur and femoral and fracture, then I get quite a number. So I have a typical femur fracture, compound fracture. Then I have the femur. Let's add shaft in order to be more specific, because we have quite a number of possibilities here that are offered. Femur shaft fracture, that was your favorite choice. There's one for closed or open fractures, so this was not reported. This would be an assumption, and that would. And if I click on it and again go to the browser, it's of course in shock injury, and here it's grouped under PT femur fracture. Here is the femur shaft fracture. So when I enter the information pathological, we also have a pathologic fracture of the femur. And if I go to the browser, you will see here it is. And here we have some of the terms grouped under this PT, pathological fracture, that we saw in the poll. So the fragility fracture is in there, pathologic fracture of femur, and that is in the spontaneous fractures as well, spontaneous bone fracture. So all these are considered pathological fractures. But spontaneous bone fracture would not be appropriate, because our verbatim does not report a spontaneous fracture, but a fracture that was caused by a low energy impact from the outside. So, and traumatic fracture, of course, traumatic fracture is also available. Here it is. Traumatic fracture was the last choice in the poll. So can the low energy impact be considered a trauma? So again, difficult to decide. Switch back here. So what is a trauma and what is the meaning of traumatic? Here a clarification of these terms from the CDC website. Traumatic events are experiences that affect people emotionally or physically. They include acts of violence, natural disasters, car crashes, other accidents. So impact from outside. And a trauma is the physical, cognitive, emotional response caused by this traumatic event. So trauma, traumatic events always relates to external events. And here's a screenshot from the website of the WHO that helps to understand the condition. So fractures that are caused by low energy trauma are considered fragility fractures, because somehow the bone must be fragile to break due to low energy trauma. It is an impact from outside, but it is low energy, and it would usually not cause a trauma. And we can see that fragility fractures are often caused by osteoporosis, but they may also occur because of other conditions. And that is why the LLT osteoporotic fracture would not be appropriate in this instance. Would be an assumption. So always consider all information that is provided for a reported fracture. And clearly distinguish fractures based on their etiology, like traumatic fractures, and distinguish them from pathological osteoporotic fractures, spontaneous fractures. And to achieve consistencies when coding fractures, especially when these are relevant for your product portfolio, it would be really useful to add some prioritization rules to your coding conventions regarding the affected site, type, and etiology of the fractures. So we would suggest to code to either LLT pathologic fracture of femur when prioritizing the affected site, or to fragility fracture when prioritizing the etiology of the fracture, the fragility of the bone. This will then depend on your coding conventions, but both of them are grouped under the same PT, that is pathological fracture. Any questions?
No questions or comments, Carol Ann. I think maybe the group's still taking in all the advice you've given there. We've got one now. Why not the shaft? Why not shaft of tumour? I'm not sure you mean femur, I think there. And you've explained that.
According to the term that you have suggested. Yes, because we have a very specific term. Overall, what we saw from the literature, this low energy fractures, these have to be considered pathological fractures, because usually with a low energy impact, if you don't have any underlying disease, you would not suffer a fracture. No. That's the first thing. So you cannot just code it to femoral shaft fracture, because you would lose the information that it was a low energy fracture, a pathological fracture, because it would not usually affect a patient who is healthy, with healthy bones. So it is a pathological fracture. And now, depending on your coding conventions, you could then say, well, either I code it to pathologic fracture of femur, because I want to capture the affected site as well, or you would like to prioritize the etiology of the fracture, the fragility of the bone, and that it was a fracture that was caused by low energy, low impact from the outside. Then you would assign LLT fragility fracture. Both are considered. Also the fragility fracture, also the spontaneous bone fracture are considered pathological fractures. This really depends on your coding conventions, and that's why I said it's really useful to add some prioritization rules to coding conventions, to give guidance to coders to achieve consistency in approaching similar terms, similar verbatims.
So
any further questions?
I think the rest of the group agree with you, Carol Ann. No other comments in. And just I would add to that, when I was, from my own experience in the industry, this was something which was important to capture in our coding conventions when it was pathological. And why has the reporter mentioned here low energy, other than to tell us there's something abnormal about it? It's not typical fracture.
Yeah, I agree. We also had prioritization rules for such terms in our coding conventions.
That's true of quite a few of the terms we've covered today, actually. I think nearly all of them we had conventions for on these topics.
Yeah, also the feelings of.
Feelings of, yes, and the bleeding. So no other comments, Carol Ann. We've given the, so I'll take the presentation back.
Just take it back, Jane.
Thank you. And we see now, you should see my screen. We're now looking at a term called yellow-coloured nasal discharge. So what's being reported here and what's important to capture? Is it the colour? I'm using the American spelling there because that's what's reported in the term. Is it the colour, or is it the fact that there's discharge? How much discharge is there? Do we know that? Is it actually reporting an infection by saying it's yellow coloured? Are they saying that they suspect it to be infected in some way? So would we say, well, it's a possible, or is that a jump? What is the most appropriate LLT here? It looks like quite a straightforward term, but when you actually stop to think about it, so is it rhinorrhea, rhine meaning nose, rhinorrhea meaning discharge, rhinorrhea, discharge from the nose? Is it purulence? And you'll see I've got a Dorland's definition for that shortly. Is it purulent rhinorrhea? Is it nasal discharge discoloration? Nasal discharge watery and excessive? Nasal mucus increased? Are they reporting that there's more of this discharge than we would normally expect? Or is it that we can code it based on what we understand? Can we make it bacterial rhinitis, or is that too much of a stretch? So let's see how your votes lie. Just over half of you have voted so far. That's it. A few more. I'll leave it. I'll just see. I'll leave the vote open, but I'll let's see what your thinking is. Nasal discharge discoloration is by far the strongest candidate there. Yes, I'm pleased to see that, because that shows that all the things we teach you when we do these sessions is obviously filtering through, and you are coding as reported when I see that. Few of you have chosen some of the others, purulent rhinorrhea, based on the fact it's yellow. Can we do that? Or now you're changing. So let's move on. Well, let's look at the definitions again. Dorland's is our go-to medical dictionary, although there are others that you may choose. Rhinorrhea is the free discharge of a thin nasal mucus, just nasal mucus, but discharging freely. So there's more of it than you would expect. We haven't been told that, but unless the fact there's discharge is telling us there is mucus coming. Purulent means that it's pertaining to or consisting of pus. Another word for this is suppurative, caused by pus. Another synonym may be pyogenic, pus forming. And just a note there, we've got another definition, and this will come more clear why we've included this when we do our browsing. Otitis media suppurative. Now, this is showing us what the word suppurative means. This is otitis media with the discharge of pus. In this case, because it's coming from the ear, it's otorrhea. And it's infecting bacteria, usually Streptococcus or Haemophilus influenzae or Staphylococcus aureus, maybe acute or chronic. So we haven't got otitis media, but I just wanted to highlight for you the meaning of suppurative, how it relates to pus, and in this situation, most commonly bacterial. So can we make any of that? All we've told is that the discharge is yellow. Can we make any of those assumptions? Well, let's go to the browser and see what we can look at here. So let's start with nasal discharge, start with the exact words. Let's see what's available and the placement of the terms. Nasal discharge is an LLT, an exact match. We have nasal discharge discoloration with both British English and American English spelling. The nasal discharge watery that I gave you, then purulent nasal discharge. So nasal discharge discoloration is the PT. It's an upper respiratory tract signs and symptoms, and it's in the respiratory thoracic and mediastinal disorder SOC. Purulent nasal discharge goes under the PT of rhinitis. Rhinitis, itis being inflammation or in many cases infection. And these are all coded in MEDRA to the infection SOC as a primary. So you see over here, once you code it to something with purulent in it, then you're putting it into the infection SOC. It goes under upper respiratory tract infections. The fact it contains pus, we don't know that. We don't know it contains pus, but we do know it's yellow. Is that what the reporter is trying to tell us? So let's just have a look there at suppurative, just for completeness, to show you, because we mentioned that otitis media in Dorland's is considered to be bacterial. So you see that MEDRA has terms in it for suppurative and purulent. So we've got different sites here that are, there's our otitis media suppurative, and it's in MEDRA, it's placed under the HRGT of pathogen unspecified. It's based on the site, the ear. There's no assumption there that it's bacterial, but we could click on some of these others just to see. I won't go through them all, but just to show that it's not always consistent. Sometimes the placement of suppurative terms in MEDRA, as we see here with labyrinthitis, is under the bacterial infections, not elsewhere classified HLT. So you can't make any assumption that it is the same with lymphadenopathy. It's considered to be bacterial. So suppurative again means pus forming. It's bacterial in some cases in MEDRA, in some cases in Dorland's. Cholecystitis is not, though. You see, just pathogen unspecified, pus formation, but it's no placement based on bacterial. So anyway, that's not what we've got reported. We could do the same with purulent. Can we make that call? And I think most of you would know and tell me, no, we can't make that call. Just because it's yellow, we can't assume. We may want to follow up and ask, is there an infection? But we can't make that call. And you can see there by entering both purulent or suppurative, you see how many terms there actually are in MEDRA. We can see purulent meningitis, for example. That one again goes with bacterial, but not all of them. Purulent discharge or purulence, that was another of the ones I gave you. Just even purulence, meaning the pus formation. Purulence, and that's under infections, of course, pathogen unspecified, and their site unspecified, not elsewhere classified. So let's go back to where we were. You might think, why are you going through all this? That's not what's reported. I just want to emphasize, and it's a chance to show you what terms are in MEDRA. We always prioritize the abnormality. So we wouldn't code it just to the fact it's a discharge. We want to capture both the discharge and the site of the nose. Remember, when you do look at any terms in MEDRA, you'll think of the stem, the prefix, suffix, the Latin and Greek origin of the term, whether it's rhino, aurea, leuco means white. I couldn't find one for yellow in this relation to discharge. Don't assume that the yellow discharge indicates purulence or is an infection. And I may have tried to trip you up in the poll, but you weren't having it. You were, all of you, well focused there. Nasal discharge, discoloration. I've used the American spelling for discoloration because it's worded with American spelling in the verbatim, and code as reported, as you all did. Well done. Well done. Any questions or comments, Carol Ann?
No questions. Seems to be very clear.
Good. We thought that was clear. And this is another one too, which you might also find straightforward. Folliculitis on the cheek. What's being reported here? Is it a specific diagnosis? If folliculitis is on the cheek, is there a synonym for this? Is there a diagnosis or a synonym that means folliculitis on the cheek? Can we capture the site? And is it important? What would we select? Dorland's again. Folliculitis is the inflammation of a follicle or follicles, usually referring to hair follicles, sometimes to other types of follicles. But in terms here, mostly it's going to be hair follicles. And you see there that there's a pustule forming where the root of the hair comes out. The pustule is pierced by the hair. You see that in the picture. Here are even more pictures for you. This is from another very good website that's useful for skin coding, DermNet. Here, folliculitis means an inflamed hair follicle, as we've been told. Inflamed, not necessarily infected. The result is a tender red spot, often with a pustule. Infection can come along afterwards, or it can be linked to acne. Pustules related to acne, not primarily a skin infection. Can be superficial or deep, can affect anywhere that there are hairs. So the common sites are the chest, back, buttocks, arms and legs. But the face, of course, has a beard, so that is also a hairy area. And it could be on the face, it could be related to acne, because that would be a type of folliculitis. Again, more pictures for you. Here we see some on the face. And we see how there may be a bacterial infection which follows. And you see there the aggravation. Top right, we're seeing the pustules really becoming pussy there. Suppurative, purulent, whichever word you want to use. And there we see on the face around the beard. So knowing it's on the cheek, can we therefore assume it's related to the beard? Let's browse MEDRA. We'll have a look at folliculitis and see what we get. Again, always start with the reported term. Folliculitis, the reported wording. Is there anything there that gives us a report of folliculitis on the face, on the cheek? We've got genital reported as a specific site, LLT. We've got scalp as an LLT. We don't seem to have one for the cheek or the face. I looked through them. There's more eyelid as a site, but ours is cheek, so that's no good. There is one of Folliculitis barbae. So that makes me think barber, beard, barber, maybe that's worth looking up. And when I see the placement of this, it's folliculitis. Medra puts all the itis terms, inflammations and infections. It always assumes worst case scenario and groups them under the infection sock. So folliculitis barbae goes under the bacterial infections, but is that what we want? Any others? We've got pseudofolliculitis. That's something I'll also go and reference just so I understand what it is. And we have pseudofolliculitis barbae again. So this one isn't in the infections. This is a skin problem. Pseudo meaning false. So it's something which probably resembles folliculitis. That's what I would think of. And this barbae, which we need to look at. So pseudofolliculitis isn't considered to be an infection. And there's a barbae version or just a plain pseudofolliculitis. We can have a look at the PTs for those. Both of those have a PT of pseudofolliculitis, whereas folliculitis barbae has its own PT. So where is that? And we've seen that one's placed in the bacterial infections. So what we have though is just this folliculitis. And we can go to the browser. It is in the infections under bacterial infections, folliculitis. That would fit with what we've been seeing. Pustular folliculitis fits with what we saw in the pictures from the medical dictionaries. So let's go back to our slides. Pseudofolliculitis, again, I went to Dorland's to show you it is a skin condition resembling folliculitis when you see pseudo for anything, and there's a picture. So we can see the little hairs actually coming through, causing the inflammation, and those hairs are going in all different directions. So when we looked at the definition of pseudofolliculitis barbae, this is a condition resembling folliculitis that does involve the beard. So it is around the cheek region, but not necessarily. Our cheek may not necessarily be the beard. It's commonly seen in men of African descent who have curly hair and therefore formerly thought to be bacterial, no longer so. That's the placement we're seeing in Medra as a skin problem, not an infection for this pseudofolliculitis. And the cause is ingrowing of the hair. That's why we're seeing them in all angles, because they grow, curly hair would grow sideways and could cause this. After shaving, it's known as razor bumps. So how would you code it? I haven't given you the poll yet. I've given you all the options. How would you code our report of folliculitis on the cheek? Is it folliculitis, folliculitis barbae, which is our shaving problem, pseudofolliculitis, pseudofolliculitis barbae, pustular folliculitis, or bacterial folliculitis? What can we make of our report? See where your thoughts lie. Folliculitis most common there. Again, code as reported. A few of you are selecting the barbae option, either folliculitis or pseudo. But that's not what we've been told. We've been told it is folliculitis. Go with what's been reported. Really, I can't emphasize that enough. Code as reported. Use your medical judgment, but don't make assumptions. So prioritize the medical condition over the site. So folliculitis is what's been reported. Regardless of the body site, let's capture the condition. The fact that it's itis and it's inflammation, and Medra puts it in the infection sock as the primary, don't worry about that. We haven't been told it's not an infection, so I have no concern. I code it as reported, select the closest LLT, folliculitis, and choose the default primary sock. Never try to change the sock. Do not assume any specific cause, so we don't assume that there is a bacterial infection. We just code it as reported. We haven't been told it's not an infection, so I don't have any concerns with that sock. Reference the condition to understand the difference between folliculitis, pseudofolliculitis, and folliculitis barbae. Understand the common sites of manifestation. So you've seen what we've done. That's the thought process. And we end up just with the simple term folliculitis, not able to capture the site. We know that the MEDRA term selection points to consider tells us that prioritization, when you can't find a term that represents the condition at the known site, you'd prioritize the condition. That's what we've done here. Comments or questions, Carol-Ann?
No comments, no questions.
I was
Jane.
lucky, I think. I had two very straightforward ones here. So I'll hand back to you now for something more challenging.
Okay, here we are again. So our next verbatim tells us that a pneumothorax, tongue breaker, on the right side due to lung metastasis has been detected. So what is being reported here? And what has caused the pneumothorax? Can it be considered spontaneous or traumatic? And what would be the most appropriate LLT in this instance? Pneumothorax on the right side due to lung metastasis. Again, your choice now. How would you approach this verbatim? Would you code it to pneumothorax, pneumothorax excluding traumatic, traumatic pneumothorax, pneumothorax spontaneous, or would you even code it more specifically to primary spontaneous pneumothorax or secondary spontaneous pneumothorax? What would you do? Again, lots of choices. And I see you voting already. So let's look at your proposals. So we have a split of opinions. Some of you would just code to pneumothorax, others to the LLT pneumothorax excluding traumatic, but most of you would go for secondary spontaneous pneumothorax. Some of you would also consider traumatic pneumothorax. So let's close this poll and again switch to the browser. Here we are, and look first for the actual verbatim. So for the main part of it, pneumothorax. Let's see what we get here. So we have, of course, the plain word pneumothorax. It's grouped under the same PT. And in addition, we have hemopneumothorax, so this would not be appropriate. Idiopathic, neonatal, here's the one, the spontaneous one, separate PT, and the pneumothorax traumatic. Here it is. So let's look into the hierarchy and see what we can find there. If we get some guidance from the neighbors of the LLTs that were shown in the poll. So here's the PT pneumothorax only, and we see collapse of lung, so nothing specific. Tension pneumothorax is also in there, so nothing specific, nothing that would really capture what has been reported in our instance, in our verbatim, that this pneumothorax was due to lung metastasis. Is it a pneumothorax spontaneous? No, it cannot be considered a spontaneous one because there was a reason for it. It was the lung metastasis. Can this be considered traumatic? Remember what we saw before about the trauma. So traumatic events always relate to events that were caused by an external impact on the patient. So this was not the case here because the lung metastasis is, of course, something that the patient suffers from. It was nothing that came from the outside. And in addition, So we have the spontaneous one. It is a spontaneous one because even if there's a reason for the etiology of the pneumothorax, there is something that was contributing to this pneumothorax. It is not a spontaneous, cannot be considered as something that happens without any reason. There was a reason in the patient. It was not caused by a traumatic event, but it was caused by a condition in the patient. So let's switch back and look at some references in order to better understand the condition. First of all, a reminder on what we saw before about the definitions, explanations about traumatic events and what trauma is. And here, when looking into medical literature, we can find publications that really refer to pneumothorax in the context of malignant disease. And these conditions are named secondary spontaneous pneumothorax. So don't interpret spontaneous as something that occurs without any reason. It can have a reason, but it's something that happens spontaneously, suddenly, and can, of course, occur in cancer patients. So what we had to explore, MedDRA for the different types of pneumothorax first, and also take into account the reported event that led to this condition, the lung metastasis. We used reliable medical references to understand the difference between a traumatic and other types of pneumothorax, and found information that helped us to classify the condition. And of course, we would also have to code the etiology of the disease, the pneumothorax, that is lung metastases. So this would be our suggestion here. We would code to LLT secondary spontaneous pneumothorax under PT pneumothorax spontaneous. So it's a secondary one. The secondary indicates that there was a reason for it, in this instance, the lung metastasis, and still it can be considered spontaneous. There was no external reason for it, no trauma. And of course, you also have to ensure that the lung metastasis is captured by the LLT metastasis, metastasis to lung under PT metastases to lung. Any questions, Jane?
No. One question. Is the spontaneous more important than excluding traumatic? Yes, Yes,
it is. It is. Because with the LLT secondary spontaneous pneumothorax, you really indicate there was a reason for the spontaneous pneumothorax. And this reason, of course, also has to be coded. So the metastasis in lung.
Yes. So it's spontaneous, but there's something underlying it, is what you're saying. There's another factor, contributing factor, rather than it's not due to trauma or to a procedure. Yeah, I agree. Yeah. That's the only question or comment, Carol-Ann, so far. Hold on. The SOC will now be cancer too, which is important over a lung-related term, is what's the other comments. I think agree with you that by you're putting it. Good. So by doing that, you're able to capture the underlying, and you capture the metastases for the cancer.
Yeah. You have to split code in this instance, or make sure that this was captured at least. Yeah.
No other comments, Carol-Ann, so feel free, move on. Thank you.
Okay, the next one. Here we are told that there was a dehiscence of an anastomosis. So very clear description, but do we know where the dehiscence occurred? No, we don't know. We are not told. And is this a wound complication maybe, or a failure of an anastomosis internally somewhere in the body? And how can we code this? So first, let us look into the door lens again. So what is an anastomosis? A connection between two vessels or other tubular structures, like for instance, the intestine or ureter. So this is a anastomosis. And dehiscence is a splitting open. So a pathological separation of neighboring tissue, and in this instance of the tissues that were connected by the anastomosis. So how would you code dehiscence of anastomosis? Would you select dehiscence, surgical wound dehiscence, anastomotic complication, anastomotic perforation, anastomotic leak, or would you consider LLT failure to anastomose? What would you do? We have a dehiscence of anastomosis, and unfortunately there is no combination term that would combine this information in one LLT. So somehow we have to find a solution here, a coding solution. So I see that we have 50 responses already. So let's look. Oh, so most of you are going for anastomotic complication, but we really have a split of opinions here. Dehiscence, surgical wound dehiscence, anastomotic perforation, anastomotic leak, failure to anastomose. But most of you are voting for anastomotic complication. So let's switch to our browser again. And I would now limit my search to the injury stock because this is what we are looking at. And in order to really narrow down my search results, and first look for the dehiscence and see what we get. So we have the abdominal wound dehiscence, separate PT in this instance, sternal dehiscence, post-operative thoracic procedure complication. We have the chemo port, so some site dehiscence terms. Here's the surgical wound dehiscence that we saw also grouped. It's grouped under wound dehiscence, and then some that are more specific, indicating vaginal cuff, uterine, ureteral, and here's the wound dehiscence that we also saw in the poll. So these are the ones that we have for the part in our verbatim that relates to dehiscence, and nothing that would somehow represent the information anastomosis. So let's look for anastomosis. Again, truncating the word typo. And here we have more. Anastomose failure 2 is one of them, failure to anastomose. This was one of the options in the poll. Anastomotic complication would be another one, erosion. These are all more specific. Anastomotic leak would be a separate PT. This was also one option in our poll. No mentioning of ulcer in our verbatim, and then again, more specific terms containing information about the affected anatomical site. Intestinal, pharyngeal, spermatic, ureteric, so, and a vascular, but we don't know whether this was a vascular anastomosis or whether some other anatomical structures were put together. surgically. So what to do now? So when we have, let us look for the term that you have voted for. So for the anastomotic complication first. Go to browser, and you see that the perforation of an anastomosis is grouped under this this PT. So something that happened after this anastomosis was performed in the patient, something happened, a perforation. So same as hemorrhage can occur, an ulcer can occur. So these are this is an anastomotic complication, and obviously the perforation is grouped under this anastomotic complication, but others are represented in MEDRA as separate PTs. Anastomotic leak, here it is. Of course, if you have a perforation or a dehiscence, you would assume that there would be a leak of the liquid, either intestinal content or urine whatsoever, or blood. And but this was not reported here. It was just dehiscence of an anastomosis, and we should always code as closely to the verbatim as possible. So the failure to anastomose, where was it? It was failure to anastomose, here it is. Anastomose failure to anastomose. It's somehow a strange wording. It does not say that the anastomosis failed. It's a different wording. And when I first looked at it, I wasn't sure whether this is really appropriate for our verbatim. So what we could do now is, and I would like to show you, is to refer to the change request tool. You find it here, how to use change request, and you can directly access it by clicking on this submit change request link here, and then it will open. Of course, you will again have to log in with your ID and your password. And what this change request tool offers is that you can search the change request history. And I am now looking for our term in order to better understand the reason for adding this term to MEDRA, some rationale, some explanation what is meant by this term. And if I enter failure and anastomose and search, no records available. What you have to do, what you have to understand when you do so, that if you don't find any record for a change request, it is due to the fact that before MEDRA version 5.1, change requests were submitted by fax machines, and so all very manual process. And that's why these change requests could not be entered into the change request tool. It was only with MEDRA version 5.1 when change requests were submitted electronically, and these are all visible in the change request tool. But it's really a very useful tool, very useful feature of the tool that you can use if you're not fully clear about the meaning of a MEDRA term. That is what I wanted to show you. So let us go back to the browser then, and what we can do is to, in order to show you that this is really due to the fact that this term was added to MEDRA before version 5.1, you could also do a right mouse click here and say open history, and you would then see the history of the term also when it was added. And here it is, version 2.1. It was, I assume it was a term from a legacy terminology strange wording, but it's grouped under surgical and post-operative complications. So this is a correct placement for our verbatim. And that's why I would assume that this term best represents really our reported condition. So let me switch back to my slide and continue here. And here's a publication that really nicely shows the relevant terms in our poll and helps to clarify our verbatim. It talks about an anastomotic failure that manifests as anastomotic dehiscence. So obviously these two are somehow quasi-synonyms, anastomotic failure and anastomotic dehiscence. And this dehiscence will cause an anastomotic leak, of course, either blood or gastrointestinal content or urine whatsoever. So to find the best approach for coding this verbatim, we searched to find terms that relate to dehiscence, and we would truncate the term anastomosis to anastomo to find all LLTs containing the wording anastomotic and anastomosis. We've referred to reliable references to better understand the etiology of the condition and the related signs and symptoms. And because of the fact that there is no direct match for our verbatim in MedRA, we had to look for the best approximation for coding the reported condition. So an anastomosis is performed in order to connect separated tissue. And of course, this anastomosis should be closed. So it should really not allow any leakage of the content of the vessel or other tube, intestine or whatsoever. And that's why a dehiscence of an anastomosis can really be considered failure of this anastomosis, because the failure of the anastomosis represents as a dehiscence. So we refer to reliable references to understand the etiology and also the signs and symptoms. And and the failure term is really the best approximation to the condition, because no really more specific combination term is available in MedRA. So this would be our final suggestion. We would code to LLT NPT failure to anastomose. Any questions, Jane?
Just a couple of comments. Thomas makes a good point, I think, here, that as it stands, the term doesn't make a lot, it's not very meaningful because we don't know the site. So ideally, we would clarify the localization, the site of the anastomosis, if possible.
You're right. You're right. Often you would do so in clinical trials. You would try in pharmacovigilance, but if you work in pharmacovigilance, you may know that often you cannot get any additional information. Yeah, then you have to somehow handle this verbatim and assign the best LLT that you can find. But I agree, yes.
Yeah, I agree too. If you can follow up, it's likely somebody somewhere knows. If they know it's breaking down, they know where it is. Then the other comment we had is around, you said that the anastomosis being artificial, and we've had comments that anastomosis could occur naturally by definition. I think of an anastomosis being a surgical joining, but I don't know if you want to turn to that one. That are we happy that it is a surgical thing that's leaking? Or
I think so. This is how it's represented in MedRA as well.
And then somebody's commented that an anastomosis complication is acceptable. I think they're asking a question there. Is it okay for you to use anastomotic complication? I mean, these terms are all so closely related in meaning, aren't they, Caroline?
Yeah. So here the connection. So because of the Dorland's definition not clearly specified that this is always a surgical intervention that connects vessels or tubular structures. But because of the dehiscence, I think that we can really derive the information that this is a surgical procedure, post-operative complication.
I think so. The word dehiscence generally is used for wounds and surgical joining, isn't it?
Yeah.
Thank you, Carol-Ann. That's all so far. So I'll take it back from you, and just to wrap up, thank you. I realise we're out of time. We brought one term along as a backup today, but we didn't give you as many because we're learning that we generally don't do more than 8 in a session, 10 minutes per term. So just as hopefully you can see that as a reminder for you that we've been doing these sessions now for, I believe, 3 years, is it really? 3 years, and that we have a number of them. They're all recorded. They're available on our YouTube channel, and they all cover different verbatim terms. So if you put it together, we've covered a lot of topics, and the list of verbatims is given on the front page, or the page I'm showing here. You can look at the link for the verbatim term. You can look at the list of covered in each of the sessions. So that's something that it's on our YouTube playlist. And we also have on our website for you. I'll kick you off with the slide. Here we go, the polling. Hopefully you can see that now. There's an instant poll, so if you want to give us some feedback instantly, if you want to suggest a verbatim or a topic, do put it in, and we go back to the lists month on month when we do our preparation. As I say, we don't always come back to it immediately, but we'll do the best we can. So fill out the survey. You'll also get a SOGO survey, which is our standard survey. This is an instant poll survey. You'll also get another one that comes by email to you if you prefer to spend some time thinking about it and then putting in your comments later. So there is that. There's a link here. It says this screenshot is taken from our website. It's the contact page, top right-hand corner, quick link. You can scan the QR code to join a WhatsApp group, and you can contact us via the help desk with email, and that address is on the screen there as well. So that's what I wanted to show you. I also wanted to show you on the website that under training materials, if we go to the coding section of our training materials, Let's Code has its own section, and we have an index here. And this index, term index, is a document that lists the dates when we've been doing it. Oh, it's 4 years, Carol-Ann. Can you believe it? 4 years. There's a list of all the verbatims that we've covered over the past 4 years. Also our colleagues who do the sessions in the US. So there's a lot of examples for you. And if you scroll down, they're actually categorized. So you can see them by speciality, medical specialty, and other categorization. So if you're interested in a particular type of term, you can come and have a look, and you'll see the sessions where we covered examples, and it will help you to decide which ones you want to watch first from the YouTube channel. Okay, that's everything. Here are some contacts for you. Apologies that we're 5 minutes over time. Thank you all for your attention today. Always enjoy these sessions. Thank you, Carol-Ann, for the collaboration. I learn a lot from you, so always enjoy it. And we hope to see you again in the new year now. This is our last one, so best wishes to you all for your end of year celebrations, and we'll see you early in the 2025.
Oh, yes. Thank you, Jane, as well. And all the best for everyone. Happy New Year.
Thank you, everyone. Happy holidays, as Catherine says.
Yeah, happy holidays.
Bye-bye. Bye-bye.
Bye-bye.